coming the first thing, so very basic. So yeah, they have asked a lot of questions from the biostatistics. So the first question, that is the measure of central tendency. So I've covered this biostatistics in my YouTube video. So if you must have watched this, then easily would have been able to answer it. So the measures of central tendencies are mean, median and mode. So in this, the answer would become as mode, right? Going on to the next question. So coming to this, that is identify this instrument. So it is a Hudson brace basically, which is used in the neurosurgery, and it is basically a fixator brace or instrument. So don't worry, even if you have made mistake, this all are the instruments which are very complicated at the PG exit level to answer. So but in this, the correct answer is Hudson brace. Moving on to the next, that for sampling of a population, division into groups, then from that groups you randomly select the subject and not the group. So you select people from each group and then you do the study. So this sampling is known as stratified sampling, wherein you take the entire population, you divide it into various stratums, and finally out of that you randomly choose the people for this sample data. So that is stratified sampling. Moving on to next, so what is the coefficient relation basically? So coefficient relation means that how strong a relationship is between the two data, and the coefficient relation, it varies from -1 to 1. So it can be -1 or +1. +1 means that there is a positive relationship, -1 means strong negative relationship. What does -1 suggest? So -1 or a negative correlation, it suggests inverse relation. So what is inverse relation? That one increases and one decreases. So when one A increases, B decreases. So the answer would be this. Okay. Moving into the next question, that a patient with a CT scan, liver tumor with a heterogeneous enhancement of arterial and rapid washout, that is a very characteristic feature of a hepatoma or a HCC. Okay. So very easy, very basic question, rapid washout and arterial enhancement and a rapid washout. So that is characteristic of HCC. So that is rapid arterial enhancement followed by washout in the delayed phase. Okay. Cleft lip is due to the fusion of, so they went into a very so the questions what I felt was that if they ask direct question, they are from the specialty based, or else they've asked very clinical scenario oriented. So moving on to the next question, so that is cleft lip is due to, so this they have taken a lot of questions from Schwartz. So this is a paragraph that is given in Schwartz, that is the embryology. It is formed by the medial nasal and the maxillary prominences. So the primary palate, which includes the upper lip, alveolus, hard palate, it forms from the fusion between the medial nasal and the maxillary prominences. So in this, according to me, the answer should be this, that is a failure of fusion of median nasal and the maxillary process, according to this reference that is from Schwartz. Okay. Moving on to the next question, that is most common complications of total thyroidectomy. Remember, it is total thyroidectomy, and the answer given according to me should be hypocalcemia, because hypothyroidism is the most common complication of thyroid surgery, and this is a reference from Sapiston. Okay, so hypothyroidism leads to hypocalcemia, and I think that is why hypocalcemia should be the answer in this question. So this is a very repeat question, and if you have solved my mock exams of the Sushruta LGS, we have asked a question regarding meant to be with tongue ganglioneuromas, and the answer would be meant to be. So very straightforward question, nothing much to discuss in this. Now this is also a question which has been taken from this table of anti-cancer drugs, from which also we have asked multiple questions in our mock exams. If you have solved them and if you have gone through this table, this question would not have been difficult for you. So very straightforward, the lapatinib, it has the inhibition of tyrosine kinase, which is associated with EGFR and HER2/neu receptors. Now gunshot wound with colonic injury, and that is throughout or through and through. So that means that the colon is almost injured and it is a destructive type of injury. So if you see the reference that is given from Shorts and Sabiston both, but if you see the reference in this or in any traumatic kind of injury, that is gunshot, usually in such injuries, because gunshot, the colon is injured, there will be a fecal peritonitis. In such cases, what are the options which have been told to be by the students? So you cannot do a resection primary anastomosis, you need to divert. You cannot do a primary closure, you cannot observe. So the answer should be a diverting stoma in this case. Okay, so this should be the answer. If there is some issue in the options, please let me know so I can correct it. Moving on to the next, that is gunshot or stab, proper recall is not known, with injury to the zone 2 of the neck with 2 cm of carotid is disrupted, management. So this is again reference maybe from Shorts, wherein they mentioned regarding the repair modalities. What they mentioned is that if the arterial defect is 1 to 2 cm, you can just do end-to-end anastomosis. But if you cannot do it because you need to mobilize the artery and more than 2 cm, the anastomosis would be under tension. And as the injury is to the common carotid, not to the internal or the external carotid, so in this case the answer should be a venous interposition graft to replace that segment and do a repair. So according to me, according to the reference what I have gone through, the answer should be venous interposition graft, repair of the artery. Now high Gleason score inference, basically, so this is something which I have taken from an article, that more the Gleason score increases, it suggests that the cancer is of a more poorly differentiated category. So in this case also high Gleason score inference, that is showing a poorly differentiated kind of tumor. Okay, now female child ear deformity, microtia. So according to the reference and what I've gone through, not given everywhere. In Shorts I found it that there is a microtia with a typical figure, so that is associated with a Treacher-Collins syndrome. Now very direct, straightforward. Usually now Q SOFA score is used, SOFA score is not used, but they have asked regarding which is not a component. So as we can see, the respiratory PaO2 by FiO2 is the component. Then what you have is the creatinine. So is creatinine a factor? Yes, creatinine is included in SOFA score. Then what are the bilirubin and total leukocyte count? So what you can see is bilirubin is also a factor. So total leukocyte count is not a component of a SOFA score. So the answer should be TLC in this case. What is the gene involved in familial gastric cancer? Very straightforward, easy question. That is CDH1 is the gene associated with hereditary or familial kind of gastric cancer. Coming to this, the child with brain tumor with pilocytic astrocytoma, genetic mutation, what should be tested? So this is something, a new concept which I think I found in Sabiston, Shorts and Bailey, only given in Bailey new edition. That is regarding the classification of gliomas and the associated genetic mutations. So what they have shown is that there is a IDH mutation. So if IDH was in the options, according to the recall given to me, IDH was not in the options. So amongst the answer, ATRX loss is seen in the patients who are IDH mutant, and that is associated with astrocytoma, oligoastrocytoma, oligodendroglioma. IDH wild type will be those who are not having any mutation, genetic mutation. If they are having, that is IDH mutant, in that there is loss of ATRX gene and T53. So according to me and the reference given in Bailey 28th edition in the neurosurgery chapter, the answer should be ATRX. Moving on to the next, that is a patient with sudden onset of headache. That is important statement, with knuckle rigidity without any history of hypertension. So as we know, subarachnoid hemorrhage, worst headache of a patient's life, spontaneous origin and with knuckle rigidity, which is a component used in the Hunt and Hess grading scale. So in this the answer should be SAH. So if you see this, the Hunt and Hess grading system for SAH shows headache, knuckle rigidity and the other neurological deficits. So they have emphasized a lot on Short this time, I felt so, according to the recall what I am gathering. Then a patient with carpal tunnel syndrome, nerve block given, it was lasting for 8 hours, so that is a long acting drug. So if we take this table, the drugs which are having the duration of long, that is 75 to 200 minutes, that is more than 4 hours. So amongst the option given, bupivacaine, we also know that it is a long acting anesthetic, so that seems to be the answer in this case. Onset of which symptoms indicates high risk of mortality in aortic stenosis? Now, this is a very difficult question, I must agree. Now, what I read is that initially, this is something which I have taken from the Sebastian. So, what they mentioned is that regarding the survival, the patient presenting with angina have a longer survival. If they present with syncope, shorter survival, and if they present with heart failure, then much shorter. So the onset of which indicates high risk of mortality. So answer according to me should be heart failure in this case, according to the reference which is given from Sebastian. Now, patient 15-year-old, mild pulmonary hypertension, mitral stenosis with no calcifications, wall is pliable, treatment. So if you see the percutaneous balloon mitral commissurotomy paragraph given in Sebastian, they have clearly mentioned that it is indicated in mobile, non-calcified, thin valves with absence of moderate to severe mitral regurgitation or a LA thrombus. And if you see the table or the grading, Wilkins grading for that also, in the grade 1 it is indicated for a percutaneous balloon mitral commissurotomy. So I think the option, if it was a percutaneous balloon valvuloplasty or a commissurotomy, that should be the answer. It should not be medical or operative repair or follow-up. The answer should be a percutaneous modality. I think the recall must have been commissurotomy, but percutaneous one should be the answer. Coming to the relative contraindication for liver transplant, so this is something which is very surprising, not given in Bailey Sebastian but given in Blumgart. So in this, the answer should be relative contraindication is BMI more than 40. So HIV is not a contraindication. Then miliary TB is the absolute or totally contraindication for liver transplant, and active alcohol abuse is also an absolute contraindication. Only BMI of 40 is a relative contraindication for liver transplant amongst this option. So the answer should be BMI. Coming to a patient with surgical emphysema, the scenario given was for a injury following wall which has fallen over old man. ICD has been insured for pneumothorax. Surgical emphysema in the region of neck and shoulder. They have not mentioned regarding the clinical stability of the patient, or they have not mentioned if the patient is unstable or stable, which according to me should have been given. But usually if a patient with the ICD also, they should have mentioned regarding if the IC is blocked or the ICD is draining with the air leak also there, because pneumothorax is there. So if the ICD is patent, patient is stable, then you should observe. You do not put incision always whenever there is a surgical emphysema. You always wait if the ICD is draining well. So according to me, the answer in this should be observation. Coming to patient 15 days infant, bilious vomiting, bleeding per rectum, abdominal distension with ground glass appearance. Now again, as I said, they emphasize a lot on short this time. So this is only given in shorts, that is the ground glass appearance which is seen in the patients having meconium ileus. Now as the patient has just presented it to you with meconium ileus, you should try for a contrast enema, which usually clears it and it resolves. After that only, if it is failing, then we try for other modalities. So according to me, the answer should be contrast enema. Patient with a synchronous tumor both in rectum and cecum with well differentiated adenocarcinoma, and they've asked for a next line of management. So according to me, the options, I think it is incomplete. If they have total colectomy with a proctocolectomy, that should be the option, because it is nearly 10 centimeter above. So you can go with a colectomy with a anterior resection with a iliorectal or ilioanal anastomosis. So if the option is total colectomy, that should be an option. There is no total or subtotal in this case, so I am not sure. But according to the paragraph given in shorts, that is a patient with a synchronous tumor that is having field defect, that is both colorectal neoplasm, there should be a total colectomy in that patient. So if the total colectomy was the option, then I think that should be the answer. Now this is a very difficult question, that is regarding the iliac bone grafting. I had to search a lot for the references and could not find according to the options given, but what I found was that it is iliac bone can be taken up to 16 centimeter of graft can be taken. It is used for mandibular reconstruction, so it is resembling mandible. As it is an autologous graft, so the osseointegration is also easy, and as the iliac bone is a very prominent and external structure, easily exposable, so the osteotomy is not difficult, and according to me the answer should be osteotomy is difficult in this case. Choledochal cyst resembling type accessory gallbladder, very easy, very straightforward, that is it is type 2, that is what you see in this figure, that is taken from Sabiston. So it is straightforward type 2. Now ATLS, site of needle insertion in tension pneumothorax, so it is changed from 2nd to 4th to 5th, and according to me the recall was 4th to 5th intercostal space anterior to anterior axillary line. Actually it should be anterior to the mid axillary line, so there's a reference taken from the ATLS recent edition. Pregnant woman with breast cancer, I had asked a question from this topic of pregnancy with breast cancer, which is given in shorts, and they have asked the question from the same topic. So I have been trying to cover all the important topics in my content. So in this, neoadjuvant is given in 2nd or 3rd trimester. Mammography is not sensitive. Lobular hyperplasia can resemble malignancy. So here it is not having poor prognosis compared to non-pregnant. So the statement that is given at end, that is pregnant women with breast cancer have a prognosis which is similar to that of non-pregnant breast cancer. So the false statement should be B, that is poor prognosis compared to non-pregnant women. Triad of RCC is straightforward from the 27th edition of Bailey. So the answer should be the classic triad is seen only in 10% of the patients. Okay, straightforward question. Blood supply when the brain ischemia occurs, taken from Bailey and Love. So the answer should be less than 20. Normal is 55. If it goes below less than 20, then ischemia results. D2 gastrectomy, which of the following is included? So splenic is included, middle colic we don't do in D2, retropancreatic we don't do, atocaval we don't do, we only do splenic usually. So it is splenic is the answer. So D1 is up to station 1 to 6, D2 is 1 to 11, and when we go up to 16 then it is D3. So middle colic, retropancreatic, aortocaval all will not come off or become a part of D2. Usually splenic is included in D2. Again, this is a question which is I could not find in the conventional textbooks. I needed to search articles for the same. So if we see the serrated pathway, in that also they asked regarding a sessile serrated pathway. So the genes involved is BRAF. Then you have the CIMP pathway, you have the MSI, you do not have BRAF. So you do not have KRAS in this case, you have BRAF, you have MSI, and you have SIM pathway. So the KRAS should be the answer in this case according to the article reference which I have found for this. Which of the following is not a stage of graft uptake? So we have imbibition, you have inoculation and revascularization. You may be primary contracture, actually it is occurring according to the thickness of the graft. It occurs in all the split thickness, full thickness, and split thickness, thin and thick. So according to me, maturation is not a stage of graft uptake. I could not find a solid proof whether it should be a primary contracture or a maturation, but according to what I went through in Sabiston and Schwartz, I feel maturation should be the answer in this case. Now, which is correct regarding split thickness and full thickness? Again, this has been taken from a table which is given in Schwartz, so they have concentrated a lot on Schwartz this time. So this is a table which is given only in Schwartz. So in this answer should be that they have compared, they are asked regarding which is for split thickness in compared to full thickness. So the split thickness has a lower primary contraction, so less primary contracture. Okay, then you have secondary. So the secondary is obviously more in the split thickness, so secondary is more, and the metabolic from the recipient bed is required more in the full thickness and less in the split thickness. So the answer should be less primary contracture, more secondary contracture, and less metabolic demand from the graft bed. So they have concentrated a lot from short this time. That is what I felt when I was going through the recall. Now regarding keloid, again this has been combined from Sabiston and shorts. So the keloid, they are having less collagen and less vascularity. They are usually avascular sort of, and collagen are virtually absent in keloid. Now coming to this flap sinus, arterial thrombosis is given, and if the duration was given, which I think it was given was 18 hours, then in that case you do not do a mechanical thrombectomy or saline or anything. According to me, you directly go and you do a reanastomosis. You see that the artery is thrombosed, so you always need to go open up the anastomosis and clear it, and you need to need to redo the anastomosis. You cannot do by anything else in arterial thrombosis. You cannot do by mechanical thrombectomy. You need to open the anastomosis and you need to redo it. You cannot do by just doing thrombectomy, heparinized saline, and you close it. You always need to do a redo anastomosis. Post-hepatic IVC bleed, which is a straightforward taken from this description given in the Sabiston trauma. So always you go for a complete vascular isolation, that is with a Pringle. You try to search by Pringle, or if you are unable to stop the bleeding, that means the retrohepatic, so you need to do a atriocaval sort of shunt, that is a complete vascular isolation to find the hepatic venous injury and repair it. You cannot do by any other means. Surgery not done in chronic pancreatitis, very straightforward, easy question. It is Appleby. Appleby is used for a celiac artery involved cancer of the pancreas. When you resect it with a celiac artery resection, that is known as Appleby procedure. All others, that is phrase, that is a head coring with a lateral pancreatic jejunostomy. Dual is a covering of the pancreatic just distal dissection with anastomosis, and burn is a duodenal head preserving resection. So these are all for chronic pancreatitis. Appleby is not used for chronic pancreatitis, it is used for pancreatic cancer. Now this is a question which I needed to go to the articles on net to search which of the following is used for chemo prevention. So I found an article wherein metformin has been prescribed, which has anti-cancer properties, and it is used for chemo prevention. So answer is metformin. Final bowel position after LATS procedure, very easy, that the cecum colon lies to the left and the small bowel lies to the right. Very nicely explained and given in the Sabiston, wherein after repair the cecum lies to the left and the intestine is put, that is small bowel lies to the right. So small bowel to the right, cecum and colon to the left, and that is why we also do appendectomy in patients wherein we are doing a LATS procedure. Least effective dye, so we use methylene blue. Sometimes we combine methylene blue and isosulfan. We use technetium sulfur colloid. ICG is a least effective dye for sentinel lymph node biopsy. More commonly we use isosulfan blue, methylene blue and technetium sulfur colloid. Double bubble appearance, postnatal, non-bilious vomiting is slightly confusing, but if they have given a double bubble, you should blindly answer duodenal atresia. Pyloric stenosis will not have, it will have non-bilious, but it will not have a double bubble appearance. Esophageal stenosis will never present with double bubble. Gastric volvulus also will not have double bubble. So you, in this case, the answer will be duodenal atresia, which we have also asked in one of our mocks. A young boy, non-healing fracture of femur with TTH increase, calcium hypercalcemia, systema is showing a foci in the posterior mediastinum. So the diagnosis, according to me, as per the references, that is again from shorts. So the hypercalcemia, which is associated with malignancy, that is commonly with bone mets and solid tumors of lung. They usually have hypercalcemia, and in this case, if you see the adenoma, that is parathyroid, intrathymic, superior parathyroid gland adenoma will never present with a non-healing fracture of femur. And parathyroid carcinoma will have a PTH that is almost 5 times the normal. So in this case, according to me, the answer should be a lung malignancy secreting PTH related peptide. Coming to this lady, urine recurrent stones, UTI, high PTH, calcium levels, normal phosphate, vitamin D levels. So it is a very straightforward that it is pointing towards a primary hyperparathyroidism. Okay. IAP measuring best is a bladder pressure monitoring. Again, this is from shorts, so they have taken a lot of content this time from shorts. So abdominal compartment syndrome, bladder, the vesical pressure monitoring is the commonly used, and so in this the answer should be a bladder pressure monitoring should be used for the measurement of intra-abdominal pressure. So this is again taken from shorts, and the most common technique to measure is that is given in here. That is most common technique is given is patient bladder pressure. Active bleeding is splenic trauma. Free fluid will not suggest that there is active bleeding. Subcapsular hematoma and perisplenic hematoma will also not be suggestive of active bleeding. When you do a CT and you see a hyper-attenuating lesion or the foci in the spleen, that means there is a active contrast extravasation. So in this case the answer should be B, that is hyper-attenuating foci in spleen. If you see the ask grading also, if there is any active bleeding and there is an image which is given in the Sebastian, that is splenic trauma with a hyper-attenuating foci in the spleen, that is suggestive of active bleeding. So the answer should be B. Now this is a question which is repeat directly, which has been asked in our mock, that is the contrast agent used in contrast MRI lymphangiography, and answer is a gabapentin diameglobin. Answer is from a Sebastian 21st edition. Gaze paresis. Now many of you have answered uncle herniation, but actually the answer is a brainstem or a midbrain dysfunction which is given in Bailey, that is midbrain or brainstem dysfunction may produce gaze paresis, that is inability of the eye to look across beyond the midline. So if the option was brainstem or a midbrain dysfunction, then the answer should be that. Now this again repeat from what we have asked in our mock, that is the 10-year patency for Lima is highest, that is 95. They asked in a different way, that is the best 10-year outcome is associated with graft, so it is Lima. Rima does not have, we use Lima, and in venous graft the patency rate is only 50 to 60%, so the answer in this case is Lima. And which of the following is the last question for this session, that is selective shunt they have asked, directly taken from Bailey, and the D is a distal splenorenal shunt, so that is a selective, all the others are a non-selective kind of shunt. So the answer in this should be D, or the figure which is showing a distal splenorenal shunt. Starting with today's session, first of all is the question on Bergsonian bias. So basically it is when you do a study but you do not take a sample from population but you take from a subpopulation. So that is basically what is Bergsonian bias, and in that is not representing the general population. So the answer in this case according to me should be not representing general population. So you do not take, for example, if you are doing a study, you only take the patients or the people in your hospital, you do not take from the community. So if you are taking the study population in the hospital, does not mean that it will represent the whole community. Now coming to the eye sign, so with this is, I think this has been told to be by the students that this is the image which was asked, and the answer is Darrell-Impel sign, that is a rim of sclera is visible all around the eye, all around the cornea. Now this is a very straightforward question which was asked, that is bilateral cobra head appearance, that is for bilateral uretrocele. Now best study to know association between risk factor and a disease. So I would say that I had asked this question regarding the studies in our mock test, and this is something from this table from where it has been taken. So if you see the table, there are two things which can be asked, that is it can be cohort or case control, wherein you can study the exposure and the multiple outcomes. Now they have asked the best one. So if you see the weakness in both case control and cohort, so the cohort has some potential to establish causal effect, that is the disease occurring to that due to the risk factor, and case control has limited potential. So according to me the answer should be cohort study, but this is something which can be, some of you are telling ecological, but ecological I don't think is the answer. I would suggest that it is mostly cohort study in this case. Now this, what all are the cutaneous manifestations of spinal dysgraphia? We had asked this question in a mock exam. So it will show hemangiomas, hair tuft, diadermal sinus tract. So ABC are all correct. The fourth option, which many of you have not been able to recollect, that is the incorrect answer. So these three are correct. So this cannot be the answer in this case because they've asked all except. So in this question, dermal sinus, tuft of hair and capillary hemangioma are correct. Amoxiclav, anaphylaxis with drug is not used. You don't need to go into much detail. Chlorpromazine is an antipsychotic drug, and that is the answer in this case. Okay. Liquid biopsy, identify the true statement. So basically it measures the DNA, ctDNA in the serum, and it can help in identification of the circulating HPV DNA. So basically, first of all, understand that liquid biopsy is for the ctDNA measurement in the serum, and it can be used in cervical cancer for the HPV DNA measurement. So D is correct according to me in this scenario. Now, a young boy, penetrating trauma to left lower chest with cardiac injury, unstable patient. So already the Bailey new edition has corrected that there is no role of pericardiocentesis in a penetrating cardiac or myocardial injury. So in this case, with cardiac injury, penetrating injury, the ideal management according to me should be immediate surgery or exploration. You cannot wait and resuscitate for the patient to stabilize, because already patient has a penetrating trauma with cardiac injury, so you should go for a bit direct exploration. This image was asked, that is regarding the crossed ectopia, and it is unfused. The both kidneys are separate. I think this is the image which was asked. So in this answer will be a crossed unfused ectopic kidney and not fused. Now coming to the next, that is Limburg. Very easy, very straightforward. It is a rhomboid type of flap which is very commonly used in a pulmonary sinus management. Now breast flap with the lowest abdominal wall, morbidity. So according to what I have discussed with the plastic surgery faculty, the answer is diaphragm in this case, which has the lowest abdominal wall, morbidity, that is deep inferior epigastric artery flap. Okay. NSAIDs are used for cancer prevention, and which cancer it is used predominantly. So I could not find it book, and I've searched the articles, and in that it is given that it is a most promising agent in the chemo prevention of colorectal cancer. So in this case the answer should be colon cancer. Patient coming to a OPD, young patient, blue dot sign. So it is a very straightforward that it is a testicular appendage torsion. Okay. Now Tokyo guidelines, very straightforward. Again, it is used for acute cholecystitis, so nothing much to discuss here. Chest injury with sucking wound, that is an open pneumothorax, so you do not close it. You either put a ICD remote from the wound side and then you close the wound. But if you don't have that in option, then you go for a three-way plaster closure. That is, you put a dressing and only tape it on the three side, keep it open on the one side. So that is what you can do as a next step. Other than that, if you have option as ICD with closure of the wound, then that should be the answer. But in this case, that is not given in the option. So the answer is three-way plaster closure. Old age with end-stage kidney disease, with coronary artery disease, lung metastasis, cholecystitis, sepsis, severe cholecystitis. This is an indication for a tube cholecystostomy. There are very few rare indications where you do a tube cholecystostomy. Other than that, you do not do cholecystostomy even if the patient is having severe cholecystitis, but this patient is having meds, old age, severe comorbidities. So in this case, it is a clinical scenario. So this is a clinical oriented, clinical acumen based question. So in this answer, according to me, should be a tube cholecystostomy. Patient, young boy, hyperparathyroidism, next line of investigation, it should do biochemical. If not given, then you should go for a USG neck to see for the parathyroid localization. You try to identify if there is any abnormality in the neck. You do not do X-ray directly, you do not do PET scan or a DEXA scan. First is biochemical. If not given, then you go for a USG neck. Solitary discrete nodule in a 50-year-old male, CT better than MRI, more risk of malignancy in men, no malignancy risk, USG screening is sufficient. So in this, what I found in this abstinence is that the patients having solitary thyroid nodule in male, they have a higher risk of malignancy. So in this, if the true answer is asked, then it has a more risk of malignancy in men. That should be the answer. Now I'll just again tell you that if you feel that the question is incomplete or the options are incomplete, then please let me know in the comments. I'll definitely answer to you and try to help you reach the correct answer. I am very much like being honest that maybe the answer and the question may not match with what you have gone through in the exam, but I've tried my best to gather the accurate recall. If you feel that there is something which you need to correct it, then please let me know in the comment section. Old man with heartburn, regurgitation, UGI endoscopy image was given. This is not the image, it was closely resembling this, which was suggestive of esophagitis with heartburn and regurgitation that may be due to a GERD. So best modality to diagnose this, so either you diagnose a GERD or you diagnose and you need to rule out in the old age with ulcer with esophagitis feature, you need to rule out dysplasia and cancer. Now with esophagitis with heartburn regurgitation, you are almost sure up to a diagnosis of GERD. So next step in this case, you do, if you are doing a UGI scopy, you do a biopsy to rule out dysplasia and cancer. After that, you may go ahead with pH monitoring and high resolution manometry, but in this scenario I would advise for a UGI biopsy. TNMS stage, that is for serum marker, that is a very straightforward question that is used for a testicular cancer. Varicose vein, SFG incompetence, treated conservatively with compression, heaviness, all are true except cyanoacrylate glue does not need post-op compression. You can do in regional and you do not, you just give the glue and you press the vein, it will be like that. You do not need to give post-operative compression like you need to give in other modalities. So according to me, C should be the answer in this scenario. So moving on to the next question, that is, many of you have not been able to tell me accurately regarding the features which was given, but you told that it was pointing towards pheochromocytoma, and which is true is us. So SDHB mutation is seen, it is less malignant in Men syndrome, it is MRI is better over CT as per Sebastian and Shorts what I've gone through. So according to me, the answer should be C, that it secretes calcitonin and PTH related proteins. Now this is an article on which basis I'm telling you that it may be the answer, because sporadic pheochromocytoma may secrete calcitonin and may cause hypercalcemia by non-parathyroid hormone mediated mechanism. So according to me, the answer in this scenario should be C. Coming to next, old age men, edentulous mandible, oral mucosal cancer. It is infiltrating into alveolus, so the answer should be a segmental mandibulectomy. Why not marginal? Why not radiotherapy? Why not observation? Because one, it is an oral cavity cancer, which is extension into the alveolus, and it is infiltrating into it. It is not just eroding it. If it was eroding, you can go for a marginal mandibulectomy, but as it is eroding, it is invading, infiltrating into it. According to Bailey and Sebastian, the answer should be a segmental mandibulectomy. Okay, so as you have seen, bone invasion will demand segmental resection of the mandible. Now this annular pancreas, and they've asked regarding the management. So straightforward, duodenostomy is the answer in this case. You cannot do ERCP, you cannot divide the pancreas, you cannot do a RYGJ. Parotid tumor, which is not involving facial nerve, but in the question it is given as squamous cell carcinoma. So remember that squamous cell carcinoma is a high grade malignant tumor in the salivary glands. So you cannot do a conservative parotidectomy. According to me, the answer should be a radical parotidectomy, because even if you feel the literature mentioned in Bailey, Sebastian Shorts, and also in the articles have said that even if you need to remove and you cannot go over with resection without removal of the facial nerve, also you should go for a radical parotidectomy, because doing a total conservative in a high grade malignant tumor like SCC will lead to further risk of recurrence. And also, according to all of you, the image was given with a parotid tumor which was almost extending and invading into the skin. That becomes a T4 tumor. So in that case, always the management should be a radical parotidectomy. Now this is something which all of you are discussing, either this was the image or this was the image. Now remember that one tube which is going from outside and it is entering into the bile duct, not entering into the hepatic duct. That means that it is not either percutaneous transhepatic or a PTBD. It should be always T-tube cholangiogram or T-tube cholangiography. It cannot be intra-op, because you can see that it is a post-operative X-ray. It cannot be PTC because it is not going into the hepatic ducts, it is going directly into the bile duct, and it is not a ERCP cholangiography because you are not able to see the endoscope. So the answer in this case should be a T-tube cholangiogram or T-tube cholangiography. Ruben flap not mentioned anywhere where I couldn't find this, but according to the online articles and everything, Ruben flap is basically based on a deep circumflex iliac artery. Okay. Now this is the image which was given to me by many students with some clinical scenario. Now it is obviously very straightforward, pointing towards intussusception. Now, which of the following cancer is highest risk in HNPCC? Many of you have told me that there was something that it is not colon cancer, and HNPCC what should be the next cancer, but here it is straightforward that endometrial is the most common extracolonic cancer in patients with HNPCC. So the answer here should be endometrial cancer. Now, which of the following feature helps to differentiate between Crohn's and ulcerative colitis? Very straightforward. Skip lesions in Crohn's, granuloma in Crohn's, perineal in Crohn's, and transmural involvement is only seen in Crohn's. So the ABC are incorrect. So here the answer should be D, that is transmural involvement is seen in Crohn's. Now, which of the following has high association with rejection? So very straightforward. The answer is HLA-DR according to the Bailey 28th edition, that DR more than B, more than A, more than C. Now coming to a 4-year-old inguinal swelling which increases during the day with no cough impulse, and it should imply that it decreases when the patient is sleeping at night, but it is not reducing on lying down, and it is not having any cough impulse. So that is more in favor of a congenital hydrocele than a congenital hernia. It cannot be a varicocele or epididymitis because it is asymptomatic with only increasing in the day, no cough impulse. So here the answer should be congenital hydrocele. Now this CT scan image with a patulous fish mouth like appearance of the ERCP and the ampulla, which is pointing towards IPMN, and the triad was asked. So the triad in this case is the Ohashi triad. Ohashi triad, that is in ERCP, that is a bulging ampulla with mucin and dilated MPD, which is seen in here in the CT scan. So this answer is Ohashi triad in this scenario. Moving on to next, old patient with CKD, patient not taken dialysis, creatinine is 5, femoral popliteal pulse is present, post-traumatic ulcer is present, non-healing toe O2 saturation was less than 27. You cannot directly do a CT angiography. Creatinine is high, CKD patient, you cannot directly amputate. It is a non-healing, but it is not ischemic or gangrenous, so the amputation is ruled out. The option remaining are CO2 angio and angioplasty or a dressing. Now you need to see that if the ATA, PTA, everything, what is the status of that pulsation, even if you are not able to palpate it. So in this scenario, because of this patient status of CKD, the answer in this case should be a CO2 angiography followed by angioplasty, if at all it is possible. You cannot just do away with dressing without seeing the status of the vessels. What is the status? So in this case, because of the high creatinine, you should go for a CO2 angiography. Direct question, this has been taken from short. They have taken a lot of questions this time from short, that is what I felt. So CTLI in ischemia, that is the chronic limb ischemia. So what is the feature of ankle pressure and the toe pressure? So they have given two things, that is, one is ischemic rest pain occurs when the ankle pressure is less than 50 or toe pressure is less than 30. But what they mentioned in the next paragraph is that patients with a chronic limb ischemia is suggested when the ankle pressure is less than 70 or the toe pressure is less than 50. So the answer in this case should be ankle pressure less than 70 and a toe pressure less than 50 for this question. Now, carotid body tumor 2 centimeter from the skull base. I think there was a long question stem, but the gist was this: with which of the following is not done? So basically I could not find anything, but I found an article wherein they mentioned that a carotid body tumor which is 2 centimeter from the skull base, so it is very near to the oropharynx, and you cannot do a nasotracheal intubation because there is a risk of trauma while doing nasotracheal intubation. So in this scenario, you should never do a nasotracheal intubation. You should always go for a tracheostomy. So that is what I found when I searched. I could not find anywhere in our literature, so I needed to go and search the articles, and I found a case report and everything. So this is what I think, that in this case the answer should be nasotracheal intubation is not done, because while doing the maneuvering you may injure the tumor, which is highly vascular. So in this, answer should be nasotracheal intubation. Which of the following is true about cardiac transplant? So basically, antibody mediated rejection, this is taken from new edition of Bailey and somewhat other sources also, but I could find option B and C. So cell mediated is a T cell mediated rejection, and the donor specific, that is antibody mediated rejection, is confirmed by the presence of circulating donor specific antibodies. So according to me, the true statement in this scenario is antibody mediated rejection is donor antibody specific. Okay. Now according to the Montel classification, A to B to L2, so there are two, either B or C, that is 25-year-old or 30-year-old male with B2L2, so that is colon and stricturing. So the answer in this scenario is very straightforward, that is 25-year-old male with stricture in the colon. Umbilical swelling, 10-year-old, gurgling sound, that means it is mostly enteroceal, 10-year-old boy, so you should go and operate, you should not wait in this scenario. Jettison access baggage, so the terminology has been changed, pardon me for the spelling error. So this terminology has been changed from 27th edition to 28th edition in Bailey. So it is given in jettison excess baggage in 27th edition. That means that the cells, the cancer cells, they become more leaner and they become more stronger, leaner. So they lose the normal cellular function. So the answer in this scenario is not immortality, evades apoptosis or ability to angiogenesis, but they become more leaner and they become more stronger, and they are devoid of any other features or any other effect, and they lose the normal cellular function. So in this scenario, the answer is that jettison access baggage is they become excessive and remorseless proliferation, and they lose the normal cellular function. Okay. Now goiter occurs more in female than male. So I found multiple things on the internet that it is sometimes related to the genetic autoimmune disorder, but what I found in the articles is that the presence of estrogen and progesterone receptors, they increase the chances of goitrogenous development of thyroid gland, also leading to cancer in PTC, that is papillary thyroid cancer, in females because of this receptor. So according to me, the answer in this case should be estrogen receptors in thyroid is the reason why goiter occur more in female than in males. Patient 2-year-old, ventricular septal defect, mild pulmonary hypertension, cardiomegaly, QP/QS of 2:1, best management. Now what I found was that if the QP/QS ratio is less than 1.5, that is suggestive of a small defect, you don't need to do surgery. But if they are large defect, that is a QP/QS ratio is more, that is 2:1 or more than 2, then in this scenario you go for a VSD closure. You do not do for a observation anything, you go for a VSD closure in this scenario. Patient with RTA head injury, elderly male, watery discharge from the nose which is salty in taste, so it is pointing towards a CSF rhinorrhea. Now there is a confusion whether it is persistent or not, but if it is, this is the scenario what is asked, then in this scenario you just do observation, you just do conservative management, you do not need to give antibiotics also, that is what Bailey says. So in this scenario I would go for observation. If persistent was given, then in that case you need to do a surgical management, that is beyond 14 days. So in this question, if you have any query, please write down in the comments, so even it is better for us to understand. Now moving on to next, that is a prostatic metastatic bone metastasis in the bone, prostate cancer. What is the management? So we go for a radiopharmaceutical, that is strontium is used in this scenario. Okay. So the answer in this case, with the prostatic cancer metastasis to the bone, you go for a strontium therapy. Now this case where was a perpendicular direction movement of the swelling to mesentery, intraoperatively you go and see that it is a thick walled cyst. What is the ideal management? So that is pointing towards a not chylolymphatic but enterogenic, and in this scenario you go for excision with a resection of bowel and anastomosis. So in this case answer should be C according to me. Now which is benign cyst? So it is pretty much very easy, 2 centimeter, 3 mitosis per 50 hyperfil according to this box given in Sabiston, that is benign, not larger than 2 centimeter and no more than 5 mitosis per 50 hyperfil. So the answer in this case should be C, that is size of 2 centimeter and 3 mitosis per 50 hyperfil. Carbimazole, next investigation should be done. So carbimazole, methimazole, they are all prone to the patient developing granulocytopenia, skin rash, fever, polyarthritis, hepatitis, agranulocytosis and aplastic anemia, for which you need to go forward and see the WBC count. So if the patient is taking carbimazole, develops sore throat, that means that the patient is either having a granulocytosis or the patient may be developing some kind of granulocytopenia. So in this case you should always go for a WBC count. So in this case the answer according to me should be WBC count. So starting with the first question, that is regarding which is it true about leaf from many syndrome and the 3 common cancers is given. So the answer here is that is associated with soft tissue sarcomas, adrenocortical carcinomas and brain tumors. So this is directly taken from the table in Bailey. So in this the answer is C. Moving on to next, a patient with shoulder pain, so that means that he is on analgesic pain medication. So what is the diagnosis of the patient present with guarding and rigidity? So it is a very straightforward question. If this was the clinical scenario, the first thing what we will suspect is a peptic perforation, and so we would be going with the diagnosis of perforation peritonitis. Now there are 2 questions of SAH and many of you have been confusing between the 2 questions, and it is very much obvious. But what I have gone and what I have tried to differentiate between the 2 questions, one is SAH clinical scenario was given and true fact was asked. So according to this and according to the Bailey's image which is given, that is the middle cerebral artery or the middle cranial artery is the most affected, followed by the anterior communicating or the anterior cerebral according to the image. But as we all know that anterior communicating is most common, but according to this image given in Bailey, the answer should be middle cranial artery or the middle cerebral artery is most affected, followed by anterior communicating artery. Now most common paraneoplastic syndrome is asked. Now what I have gone through the various books and articles, and what I found is that it is associated with humoral hypercalcemia of malignancy 1. So A cannot be the answer. It is associated with a Cushingoid-like syndrome, so it is associated with more of hypokalemia, so even B cannot be the answer. And it is also associated with a SIADH-like feature, so it should be associated with a hyponatremia. So according to me, A, B, C cannot be the answer, so the best answer is D, if that is a recall what has been given. But I have not been able to find a proper reference for this question. But what I can say is that lung carcinoma paraneoplastic syndrome leads to hypercalcemia, hypokalemia and hyponatremia. So we need to go and see the proper recall, or if you have reference kindly share it with us so that we can also share to the other students. So moving on to the next question, that is a patient, young male, raised ICP, vomiting, CT scan showing intraparenchymal hemorrhage. I think there was some lateral ventricles also which were seen in the CT. There was an image. Now which is true statement? So usually intraparenchymal hemorrhage you cannot do operative, because what shots is given, what I found is that if you go and operate in this patient, sometimes you damage the axons. So it is better to just observe and maintain and reduce the ICP. So according to me that should be the answer, because you cannot do EVD in emergency department in this patient. You cannot do endoscopic clipping in basically IPH, and lumbar puncture should never be done in this patient. Basically it will not help you. So according to me, medical management for reduction of ICP should be the answer in this question. Patient mostly having a hyperparathyroidism like picture. If the intraoperative image was like this, what has been shared by the students, which was showing a normal thyroid gland with some parathyroid enlargement or a parathyroid swelling, which is pointing more towards the parathyroid adenoma than hyperplasia or metastatic or diffuse thyroid enlargement, because according to the student the thyroid is normal. But I think the image based questions can have a bias recall. So if you feel the recall what I'm telling you is having incorrect answer because of the image what I've given, if you can share the correct image, please let me know, so that after this recall session is completed, I will be sharing the completed 150 question PDF or the 145 whatever I can accumulate with the correct answers and the correct image recall. So it would be better if you can reach out to me in WhatsApp, or you can just mention the link of the image in the comment section. It would help. Inguinal undescended testes question regarding processus vaginalis, and I have not been able to find a very accurate reference in like either of our books, but what I read online is that processus vaginalis, usually it gets obliterated, what we commonly see while the testis is descending, but usually if in undescended testes there may be presence of processus vaginalis which is associated with inguinal congenital hernia. So according to me, the answer should be that it may be present. Now it is not always absent, it is not always present, and if it is present, it is not always present if this is the correct recall. So according to me, the answer should be it is may be present. Coming on to next patient with a left PUJ obstruction, pyeloplasty done with fever, pain, showing left dilated renal pelvis, that is hydronephrosis. Next line management usually is always a drainage, that is either by stenting or a PCN. Now according to the option shared, you do not do ureterocalicostomy, that is connection of the ureter to the calyx. You do not do a rhodopyloplasty immediately. You do not do a resection. Basically you go and do the drainage procedure for it to resolve on its own. That is conservative line of management, but with the help of either a PCN or stenting, depending on what the option was in the exam. Moving on to next, patient with a foot ulcer, scratching, rupture with formation of ulcer, and the image shared was something like this, that was suggestive of a malignant melanoma. Now according to the recall shared, if it was a very huge ulcer and swelling ulcer like this with blackish picture, that is suggestive of a malignant melanoma. You cannot do a core biopsy, you cannot do incisional biopsy, you should always go for an excisional biopsy. Even if it is a malignant melanoma or something else, you should go for an excisional biopsy according to my opinion. Moving on to the next question, that is middle-aged female patient with complaint of swelling of the neck. It moves with deglutition but not on protusion with tongue, so it is a thyroid swelling most probably. Single swelling, rest of the thyroid is normal, neck nodes are not palpable, so it is most likely a solitary thyroid nodule. How can you show it? So it is basically a single swelling, rest of the gland is not palpable. That is a typical feature of a solitary thyroid nodule. Now you can see that I have not been able to give a proper reference from any textbook, because to be honest, we are not able to find accurate reference for any textbook, because some of them are very clinical oriented questions and some are taken from the specialty books maybe, or from a specialty surgeon, and so we are not able to find accurate reference. So pardon me for that. I have tried to accumulate as much as references as possible for you so that you are clear with the answer. Now, not responsible for late enophthalmos. So one is that when edema occurs and it resolves, then enophthalmos can be visible sometimes. Orbital floor collapse, so obviously it will lead to enophthalmos. Ocular fat pad loss will also lead to enophthalmos, but atrophy or of extraocular muscle will never lead to late enophthalmos. The causes are either increased volume, herniation, orbital fat atrophy. Fat atrophy can lead to, but not the extraocular muscle atrophy, so the answer should be that. Patient, young 3-month-old with tilting of neck with presence of tumor, that is most likely sternocleidomastoid tumor, that is most likely fibromatosis coli, which is also the terminology. So the most appropriate management for this scenario is always physiotherapy, and it should be begin as early as possible. So your neck swelling or mass can be diverse, but usually if it is associated with a tilting of neck on one side, it is usually fibromatosis. So usually do physiotherapy according to the reference what I've got in the online articles. What is proto-oncogene? So it is basically before oncogene. So it is a gene which is normally stimulating growth of the cells, but if it undergoes some modification and then leads to development of cancer, it is known as a proto-oncogene. Lumbar puncture with presence of or on treatment of low molecular weight heparin with loss of continence and lower limb paralysis after 36 hours, so most probable diagnosis. Now as it is localized in the region below the level of lumbar puncture. It cannot be traumatic subarachnoid hemorrhage because you are done a lumbar puncture. It is always an epidural hematoma. So it is a very logical and clinical acumen based question. So I don't have a reference for this. Moving on to next, a patient with upper abdominal pain, jaundice and GI bleeding. So jaundice and GI bleeding, and according to the options what were given, the most probable answer is hemobilia, not bilhaemia. So the answer here is hemobilia. Moving on to next question, that is aorto bifemoral bypass image that is shared by you guys, that it was a aorto bifemoral bypass with what is true. So the correct answer in here is posterior peritoneum is always closed over the graft to prevent the graft leak may not be there, but something to prevent any fistula formation. Midline is transverse incision is sometimes preferred, and there are varying results according to what has been given in shorts. Heparin is given always before the clamping of aorta, not after the clamping, very much obvious. And the tunnels are made in retroperitoneum and not in the intraperitoneum, so C is also not the answer. So the best answer is D, that is posterior peritoneum is always closed over the graft. You do not keep it open in communication with the peritoneum. Now this is a question which I have not been able to figure out the exact question or the options what they are trying to ask. So if somebody can share a very accurate recall of this question with answers, I'll be happy to give the answer and reference. Coming to next, post-esophagectomy, dark brown colored fluid on post-op day 2, fever, tachycardia, features of sepsis. So that is most likely leak or conduit necrosis because a gastric conduit has been done. So this is a reference which I have got from Shackelford. So in conduit necrosis, a suspected anatomic leak, you always go for a contrast study. You do not do surgical exploration immediately, you do not do echo, you do not observe this patient, you always do investigation to rule out. So you do a contrast study that will help you in understanding what is the cause and if there is any leak or there is complete disruption of the anastomosis. So in this answer should be contrast study. Moving on to next, that is a 4-year-old child with sudden onset right testicular pain with right testis was elevated, tender, urinalysis was normal. So very easy, straightforward answer is torsion of testes. Then that should be the answer because DOR or Toupet are not associated with gas bloat. Neeson is associated with gas bloat syndrome. DOR and Toupet are partial fundoplication. It is never associated with gas bloat syndrome, which is not a feature of damage control resuscitation. So we try to maintain the blood pressure below 90, that is a permissive hypotension. So according to me, D, that is maintaining blood pressure to keep MAP above 90 should be the answer in this case, which is not a feature. Moving on to the next question, that is regarding a congenital or a pediatric varicocele. Now I have not been able to find a correct reference for this, so I'll not be able to tell you what may be the correct answer for this. So if you can find a reference for this, please let me know so that I can share with the other students also. Now moving on to a next, female with a 4 centimeter breast tumor with diffuse microcalcification, node is negative for tumor. So it is early breast cancer because the size is 4 centimeter, but it is associated with a diffuse microcalcification. That means that it is a multicentric disease. So you never do a breast conservation surgery, but it is an early stage disease. So you can go for a MRM followed by a APBI or a partial breast irradiation. So according to me and the reference from shorts, the answer should be a MRM only. Moving on to the next question, that is why is lung abscess more on the right side, very predominant and easy answer because the right bronchus is more shorter and wider and it is more straight, so compared to the left side. So any foreign body, any infective foci will travel faster and first to the right side than the left side. Moving on to the next, that is what procedure is this. So if this was the question, then it is a very straightforward, that it is a Roux-en-Y gastric bypass, wherein we create a small pouch and may do a gastrojejunal anastomosis and you do it distal jejunostomy. So the answer should be a Roux-en-Y gastric bypass for this image if this was the same. Moving on to the next, 35-year-old, neck swelling increasing last 10 years with recent onset hypertension with thyroid swelling, pheochromocytoma, adrenal swelling. So it is more likely to be a meant to be syndrome because only medullary thyroid cancer and pheochromocytoma. So what is the advice for the offspring? So this is a recall what I've got from you guys. So if it is a meant to be for the offspring, the answer should be prophylactic thyroidectomy before 1 year or at the age of 1 year. So according to me, that should be the answer. Risk of recurrence after nipple sparing or skin sparing mastectomy, to be very honest, I have not been able to find any reference in Daily, Savastin or Shorts for this. So I am very unsure now the last few questions, because I am telling you I am unsure because the questions I don't know from where they have been picked, basically because it is also tough for me to give you the answers for the same, and I can understand how tough it must be for you to answer these questions. So really apologize to not being able to find an answer for this, but I'm trying my best to find the answers for the question which I have mentioned that don't have the answers. Moving on to the next, that is a patient with multiple comorbs, elevated total leukocyte count with jaundice, upper quadrant tenderness, so that is pain, jaundice and TLC, so sepsis, so you can suspect fever, so that is most likely to be cholangitis. So next step should be antibiotics. You give antibiotics first and then you do a biliary drainage within the next 24 hours. You do not wait for 3 to 5 days. You should always go for a biliary drainage as soon as possible with antibiotic coverage. So if there is any obstruction or any cholestasis also, it will resolve. So you should always, according to me, the answer should be antibiotics followed by biliary drainage within 24 hours. Now, growth hormone excess tumor with intraventricular bleed management. Now, if this is the question, that is a growth hormone excess tumor, that is a pituitary tumor with intraventricular bleed. Now, if this is the one which I have already discussed earlier, I am not really unsure about what the question is, so I will not be able to discuss this. Moving on to next, big pituitary tumor which is compressing over the optic chiasma, approach for surgery. Now, basically you go for a transpinodal approach for pituitary adenomas, which I have seen in the literature, but as it is a very large tumor which is compressing over the optic chiasma, according to the articles what I find, the best answer according to me should be anterior cranial fossa approach, because it is a large tumor and you need to go near the optic chiasma because it is a very big tumor. So according to me, the answer should be this. If there is just a pituitary tumor has been given in the image what you guys have found in the exam, then transpinodal can also be the answer, but being a big tumor compressing over the optic chiasma, according to me, in what I have found online in the various articles, answer should be anterior cranial fossa approach, that is you do a craniotomy. Now if this was the image with a swelling in the back, that is most likely a lumbar hernia. In clinical examination, I have not been able to get accurate options for the same. So if it was a cuff impulse, reducibility and in the 12th rib border, I think that should be the answer if it was a clinical examination was asked. So according to me, that should be the answer. Ulcerative colitis, 4 bloody stools if associated with dysplasia, the ideal management according to me should be surgery. In dysplasia, you don't go for observation or antibiotics. In dysplasia with ulcerative colitis, you always go forward with a surgery. That is the ideal management. Pancreatic pseudocyst, whether to do a cystogastro or a cystojejunum, it depends not on the patient's preference, not on the base of the duration of the cyst. It depends on the CT scan and where the cyst is exactly located, whether it's near to the stomach or near to the jejunum. So the answer in this case should be according to the CT scan and the location of the cyst. Hirschsprung disease, what is the true statement? Very easy, straightforward, constricted aganglionic segment with a dilated ganglionic segment. That is the ganglionic segment proximal is dilated, distal or the aganglionic is constricted. So according to this, the answer is A. 3 sign, very straightforward, it is seen in coarctation of aorta. So moving on to the next question. Elective splenectomy, Ryle strip pulled out, postoperative 2 develops vomiting, abdominal pain, distension, very easy, straightforward, it is acute gastric dilatation. Because post splenectomy there is chances of gastric stasis and dilatation. So if a patient in the postoperative period presents vomiting, distension, you should always suspect first acute gastric dilation. So in such scenarios, always suspect the most common and simple diagnosis rather than complicated. This was the one which I was mentioning earlier, that is regarding surgery for GERD, which is a true statement. All except is asked. Gas bloat syndrome is seen with toupee. So if gas bloat syndrome was asked with toupee or DOR, then that should be the answer because that is incorrect. If a patient with pain in fingers with exposure to cold, immune investigation were normal, what will you advise the patient? Now, very confusing options given by all of you in the recall, but what I have been able to gather is that if the option had that she has more risk of connective tissue disorder, that should be given as an advice to the patient, because you cannot say the patient is having Raynaud syndrome and will develop. The patient is having Raynaud disease, but if she is having Raynaud syndrome or not, we are not sure. So you should not advise that. You cannot just advise that the patient may develop connective tissue disorders. She is not having scleroderma, she is not having autoimmune disease because immune profile investigation is normal. So according to me, the answer should be B. Moving on to next, lymphocytic thyroiditis, very easy, very straightforward. Most common antibody found is anti-TPO antibody, so that is for Hashimoto thyroiditis. Now, ulcerative colitis with presence of TSC, if this was the question, the options what you have mentioned is I have not been able to get the accurate recall for this. So the last couple of this last set of 50 questions, nearly 4 to 5 questions are such that I have not got proper recall, or if the recall what you have given you are telling correct, I have not been able to find a proper reference for the same. Moving on to the next, that is donation for renal transplant. Contraindication is all except. So according to the options given, GFR if it is 80, then you can easily take. GFR less than 70 is a contraindication to living donation. More than 80 is not a contraindication. ERAS, which is not true. Now all of you have told that this were the option, that is early recovery, less readmission, less pain, shorter stay. According to me, all of them are true for ERAS. There are not more readmission rate because of the ERAS protocol. So if this are the option, I feel recall is incorrect, because according to me all the 4 are correct. Prophylactic colectomy with ileorectal anastomosis in Lynch syndrome, I have confirmed it is not FAP, it is Lynch. Then you always go for a rectal surveillance. So if rectal surveillance is not essential is the option, it is incorrect. So that should be the correct answer in this scenario. This is a reference which I have taken from shorts. Many questions from short this time. Now, patient with burns, 4-year-old child. Now again, many confusion regarding the recall, but according to the options given, if the option was ringer without dextrose, that is the answer according to Sabiston. That is, if the child is younger than 2 years, then you should give 5% dextrose with ringer lactate. If more than 2 years, then you should give ringers without dextrose. So that is what is mentioned in SABI. Now, gastric outlet obstruction, very straightforward. The answer is isotonic saline with potassium supplementation. Now, this is all regarding the recall in this session.